as we know, better cancer screening and treatments have increased the number of cancer survivors. And today, approximately 2/3 of individuals diagnosed with cancer will survive long term. So after treatment, survivors still experience medical and supportive care needs. Those may include late effects, so consequences of cancer treatment that present months or years afterward, or long-term effects, which are cancer therapy side effects that present during treatment and continue on afterwards. And due to these needs, survivors require what we know as follow-up care. And in the 2006 Institute of Medicine report, they recommended and outlined components of follow-up care to meet these survivor health needs. However, we know that many survivors feel unprepared for the follow-up period, lack timely access to information and supports, experience poor coordination of care, and have chronic physical, emotional, and practical needs that go unmet. Interventions have been tested to improve survivors' outcomes during follow-up care. Some interventions tested have proven effective, such as various physical activity interventions, and for example, cognitive behavioral therapy for psychosocial concerns. However, others have resulted in null or mixed results, such as in results of survivorship care plan randomized control trials. And many of these studies have assessed clinical endpoints such as patient-provider satisfaction and quality of life, outcomes not necessarily important to stakeholders. And to build upon this background, I will mention Dr. Urquhart's research program has a survivorship advisory committee to help guide research direction. And I've displayed here a graphic created from many of the items that group has recognized as important to them during life after cancer, which may not have necessarily been studied in the current literature. And I'll not read through all of the examples they've provided, but I will mention some of the things they included were not being able to have children, having a lack of support, connection, and information, and experiencing emotional exhaustion. And in Birkin et al. 2018, a study identified outcomes stakeholders expected from survivorship care plans using semi-structured interviews and identified RCT outcomes using a PubMed literature review. They then mapped the RCT outcomes onto stakeholder identified outcomes. And you can see depicted in the middle of the circle here, there was some overlap between RCT and stakeholder identified outcomes, such as communication, role clarity, facilitating efficient discharge to primary care, promoting equitable and appropriate follow-up care, mitigating fear and anxiety, meeting educational and informational needs, and improving self-management capacity. However, the RCTs evaluated did not capture all of the nuances of the stakeholder relevant outcomes. For example, 2 RCTs assessed fears related to cancer, so survivor fear of reoccurrence and death, yet no RCT assessed the survivor's fear of abandonment by their cancer care provider or a caregiver's fear of reoccurrence for their loved one. None of the RCTs assessed outcomes relevant to caregivers. And you can see on the left-hand side here as well, RCTs assessed several outcomes that stakeholders did not identify as being important to them. Some examples included treatment satisfaction and health-related quality of life. This brings us to the aim of the current study, which was to further understand and identify stakeholder relevant outcomes, specifically related to follow-up care interventions and their nuances. The intent was to identify a suite of stakeholder relevant outcomes to be incorporated in future follow-up care studies. And the study was a descriptive qualitative study using purposeful sampling. There were a total of 44 participants from 5 stakeholder groups, including 11 cancer survivors, 7 family friend caregivers, 18 healthcare professionals, and 8 decision or policymakers. And the study recruitment occurred via email and social media. And recruitment for survivors and family friend caregivers occurred via cancer survivor, and caregiver organizations, while recruitment for providers and decision makers occurred via cancer programs in clinics across Canada, provincial and national organizations, groups, networks, and publicly available information, as well as snowball sampling. And recruitment continued until data saturation was achieved. And we conducted semi-structured telephone interviews. The interview guide was created with guidance from qualitative resources such as Patton and Rubin. And we asked participants to reflect on what is most important in the post-primary treatment phase of care, and what would interventions ideally do for survivors, family friend caregivers, and health systems. The interviews were audio recorded and transcribed verbatim prior to analysis, and myself and Dr. Urquhart independently reviewed and coded 3 transcripts to identify salient concepts. We then developed a code book consisting of both deductive and inductive concepts, and we used a resource from the National Cancer Institute consisting of several survivorship topics pictured here to help guide the codebook development. Data analysis consisted of coding, grouping, detailing, and comparing the data using techniques commonly used in descriptive qualitative research. Those techniques included the coding of the data, but also recording insights and reflections on the data, sorting the data to identify patterns and important features, identifying commonalities and differences across the data set, and extracting them for further analysis. We then iteratively determined a concise number of themes that hold true for the data and examined those themes in light of existing knowledge. For the analysis, we used in vivo qualitative software. So let's take a look at the participant demographics. 40.1% of participants were healthcare providers, and that consisted of both oncology and primary care providers. We interviewed participants from across 10 Canadian provinces. 4 Western provinces were included, which were British Columbia, Alberta, Saskatchewan, and Manitoba. 31.8% of participants were from this region, and 2 central provinces, including Ontario and Quebec. And 38.6% of participants were from that region. And then 4 Atlantic provinces were also included: New Brunswick, Nova Scotia, Prince Edward Island, and Newfoundland. There were 29.5% of participants from those regions. And the majority of participants were women, 72.2%, and notably, all caregivers interviewed were women. Over half of the participants were aged 40 to 64 years, and we interviewed survivors and family friend caregivers in relation to a variety of cancer types, including breast, colorectal, genitourinary, ovarian, melanoma, and blood cancers. 2/3 of survivors and caregivers identified it had been greater than 3 years since the cancer diagnosis at the time of the interview. And for professionals, both healthcare providers and decision makers, we asked how many years they had been in practice. 15.4% reported 1 to 4 years of experience, and 38.5% reported 5 to 14 years experience, with 46.2% reporting greater than 15 years experience. 5 themes were identified, consisting of the psychosocial, physical, practical, and information system outcome categories. A total of 13 prominent outcomes were repeatedly discussed and identified across stakeholders as being particularly relevant for follow-up care. Reintegration after cancer treatment was described by all stakeholder groups as one of the most important challenges faced by survivors, and therefore identified as a priority outcome to address in future research. This reintegration was described as adjusting to a new normal and characterized by ongoing challenges associated to changes in physical functioning or appearance, emotional well-being, and social relationships and roles. Related to adjustment, survivors also talked about difficulty of feeling comfortable in and entrusting one's own body after a cancer diagnosis. And many participants recognized the challenges survivors face returning to life after treatment when those around them expect them to easily resume their pre-cancer roles and activities once the treatment is completed. So one participant described this as, in quote, "I think they struggle to say, okay, I'm over my acute treatment. How do I sort of get my life back on track? How do I become normal?" Because there's expectations from those around them that suddenly they're done and they can assume those roles. And the fear of reoccurrence was emphasized by nearly all participants as being especially prevalent after treatment. One caregiver stated, "I just kind of feel like we're waiting for it to come back." And participants also discussed how age can influence one's level of fear of reoccurrence, with older adults sometimes less impacted by fear. And all participants discussed the need to address the high anxiety that most survivors experience in the post-treatment period. Anxiety was commonly discussed in relation to 3 scenarios, those being reduction in visits after treatment completion, discharge from the cancer center back to the community-based care, and awaiting results of follow-up tests or investigations. One participant said, "We were both deathly afraid that this cancer was going to return. So to have that kind of constant regular checkup was great. It wasn't great because, of course, there's incredible anxiety." And I thought that quote really illustrated sort of the push and pull between wanting the support and continued healthcare contact after treatment versus the anxiety that comes along with those visits. And in terms of physical outcomes, despite a wide range of physical needs, depending on cancer type and treatment, 3 physical outcomes were described across stakeholder groups as being particularly important to address. And the first that we'll discuss is fatigue. One participant said, "I would say fatigue is usually one of the biggest complaints from patients. A lot of it is an emotional and physical sort of fatigue." And both fatigue and cognitive impairment were commonly discussed across stakeholder groups as being highly prevalent and challenging for survivors to manage after treatment. These ongoing impacts were viewed as important physical concerns that impede survivors' ability to reintegrate into life after treatment, and particularly in regard to return to work and financial stability. And again, this is something that was discussed that has a different impact if you are a person mid-career versus someone who is retired and may not suffer a loss of income as a result. One participant said, "I referred myself to a psychologist because I really couldn't read and I couldn't do more than one thing at a time. And she allowed that sometimes it's a very short period. Sometimes it's a lifetime of having that kind of confusion, foggy brain, or I don't know what they call it. It took me years to get my speed up. I learned that no, I couldn't do more than one thing at a time. I think we've counted 7 times I burnt the carrots because I was doing something else while I was cooking supper." The next physical outcome identified was sexual health and well-being, was commonly described as an after effect of cancer diagnosis or treatment that was important for attention. And commonly cited concerns in this regard were in relation to sexual dysfunction, fertility changes, and changes in sexual intimacy and relationships. And the last 2 listed there were noted of particular importance for younger adult cancer survivors, or in reference to people who have not started a family yet and would like to. One participant said, "Because I've worked with people dealing with breast cancer, and certainly some of them had a significant body image change, you know, we'll talk about some of the challenge of getting comfortable with their own body again, and comfortable enough that they're comfortable with their partner seeing them that way. I haven't worked with as many young single women as I have like an older age group who are more settled into relationships than that. I know working with a colleague of mine who is a survivor as a young adult, talking with her about some of those issues that for some, the whole dating scene can be a challenge." And in terms of body image, earlier I mentioned changes in physical appearance as being important in relation to the psychosocial concern of reintegration. This is also connected to the physical concern here of sexual health, as changes in one's appearance can trigger changes in confidence and affect the connection to partners and sexual health. So you can see how many of these concerns are interrelated. Participants discussed 2 outcomes of particular importance in terms of practical concerns after treatment. And the first we'll discuss is return to work. As previously mentioned, a return to work is intertwined with physical concerns such as fatigue and cognitive impairment. Returning to life after treatment and connected to both returning to normalcy as well as financial stability. One participant said, "There's the new normal concerns. What's my life going to look like? When am I going to get back to doing my normal activities? Will I be able to go to work? And of course, there's the socioeconomic ones around. If I can't go back to work, how am I going to have money to pay my bills?" And participants frequently discuss the financial toxicity due to a cancer diagnosis as well. And this was linked to concerns of employment and rural versus urban geographical challenges. And one participant said regarding this, "But some of these people, especially up north, are traveling for days to get an appointment and staying overnight in a hotel. And, you know, there's usually a family or caregiver with them. And, you know, it's a lot of time and money and energy for maybe a 10-minute appointment to hear, 'You're doing great.'" And additionally, practical concerns were noted as being lower for those who were late career or retired. And participants described 2 outcomes they deemed relevant with respect to information provision. And the first we'll discuss here is knowing what to expect. So all participants discussed the importance of knowing what to expect in the survivorship period for optimizing their health and overall well-being. This included knowing one's surveillance schedule, knowing what signs and symptoms may indicate recurrence, knowing what long-term or late effects might look like, and how to mitigate those, knowing about available resources and services, and knowing that, in fact, life after cancer treatment may not return to a pre-cancer normal. And one participant said, I think the biggest issue for patients is really a lot of that uncertainty of what to expect. When are things going to go back to normal for them? And informational continuity and ensuring that there's consistency and clarity of information across all members of the care team, including specialists, primary care providers, survivors, and their families, was seen as a critical outcome in survivorship care. One participant said, I think it boils down to making sure that everyone's on the same page. So patients, primary care providers, and the cancer specialists are on the same page in terms of what to look out for, what follow-up needs to be done, what tests needs to be done, who's in charge. And I think that's really the most important piece of it. I think the most important piece is that information gets relayed to the right people. And participants described many system issues and discussed 3 outcomes in particular they deemed relevant in that regard within survivorship. The first to note is access to care. Participants discussed substantial differences in access to rehabilitation and supportive care specialists and services based on where a person resides. For example, one participant said, and with the dynamics of Saskatchewan, I mean, we have a lot of barriers that people from up north face with language and travel for treatment. So I mean, I traveled 2.5 hours. And related to access to care, participants also noted differences in one's ability to access needed services and supports based on their ability to pay out of pocket. And participants also discussed the coordination of care, both coordination of information as well as the responsibility and importance of designing and implementing interventions that improve coordination across oncology and primary care. And more broadly, coordination of care was seen as particularly important to people with more complex care issues, such as older adults, those with multimorbidity, or people who are seeing multiple specialists for their healthcare. And many caregivers expressed in their experience a lack of information transfer and role clarity across their loved ones' care providers. For example, this quote reads, we do a lot of sharing information ourselves and reports and that with our family physician, as opposed to it coming directly from the specialist. And both decision maker and healthcare provider participants emphasized the need to investigate the use of evidence-based practice supports and services. And this really stemmed from the fact that they were very aware and described a wide variation in follow-up care practices. While they recognized guidelines did exist for follow-up care, most discussed a lack of adherence to guideline recommendations, including transition to primary care across all settings. In fact, many participants discussed the need to monitor these practices as a way of improving quality of follow-up care provided. However, survivors also indicated a lack in availability of evidence-based supports. And I chose a quote here that depicts one survivor's experience with such a thing. He says, "Oh, we have a cancer workshop. We can help you through this. Do you need to speak to one of our psychologists?" I'm like, "No, I don't need a psychologist. Like, yes, it's depressing, but I can handle it. What I need is more education with data specifically related to food that I can access, or supplements or vitamins or herbs I can take that are going to help me help myself. But basically, I've been finding all of this on my own." So in summary, 13 outcomes were identified as important across stakeholder groups. They lie across multiple care domains and at the system level. Some outcomes were of particular interest to certain subgroups, such as I mentioned, older adults, younger cancer survivors, people having geographical challenges. And the findings of this study do align with prior research that has found ongoing physical, practical, and emotional needs after completing cancer treatment. And the findings provide outcomes to be studied in future research on cancer survivorship care. And though some of the outcomes identified may be easier to assess than others. As mentioned previously, some evidence-based interventions already exist to address a number of outcomes identified in this study. However, there are still challenges to implementation and access to interventions. And conversely, there are few evidence-based interventions to improve a number of the outcomes identified, including, for example, our primary outcome of interest, reintegration after cancer treatment. And there are limitations to the study we've discussed today. For example, asking participants about an ideal or preferred outcome during follow-up care and without a specific intervention in mind is a relatively abstract request to make. And perhaps another study may have provided a broader range or different relevant outcomes. And we interviewed a range of stakeholders, survivors, family friend caregivers, oncology providers, primary care providers, and cancer system decision makers from 10 Canadian provinces who've had experience with a range of cancer types and subpopulations. And thus these outcomes represent common needs and concerns experienced across those groups. However, the findings may not apply to groups not represented in the study, such as those of other cancer types, those with differing conditions, or those living in different geographical locations. So the study did address an important gap in the research, and there are definitely many different next steps for future research, one of which is we'll be writing up the findings related to interventions identified by stakeholders for follow-up care, which was actually one of the questions in the interview guide, and there's a lot of rich information in there, so that kind of warrants a separate study on its own to describe the interventions stakeholders identified. And secondly, we will focus on the primary outcome identified in this study, a reintegration, and we'll conduct a scoping review to explore any current interventions aimed at addressing that outcome. And next, I'd like to thank our study co-authors, Jonathan Sussman, Jeff Porter, Doris Howell, Ava Grunfeld, Margaret Jorgensen, and Cynthia Kendall, and the study's funder, the Canadian Institute of Health Research. And that's all. Open to discussion and questions.
Thank you, Sarah. So yeah, if anyone has any comments or questions, I will monitor the chat, or I don't think there's that many of us, on here, just sort of, I'll put in a different view here so I can try and see everyone. I think Sarah and I will probably tag team them. Hi, Emery. Hi.
Thanks so much. Hi, Robin. Hi, Sarah. Thanks so much for your presentation. It was really interesting. I'm curious, this primary outcome that you've noted, reintegration, it seems to me that there could be overlap with some of the other survivorship outcomes that you've identified in the list. And I was just wondering if you could spend a moment clarifying what you think that outcome means specifically, and how it's differentiated from some of the others.
That's a great question. I can start, and Sarah, then you can come in. It is related, absolutely, and there is relationships throughout some of the outcomes, right? But we chose to make it, to sort of frame it as its own outcome, because this is one of the, it came up, I think, in every interview, is this whole idea of people are struggling and need to figure out, and we need interventions, and we need sort of more supports around how do we sort of adjust to this new normal. And sometimes that is in relation, people talked about going back to work, and so return to work was one, right? But how do we sort of, this recognition in many cases that it's not sort of going back to normal, but it's more of a new normal, and it's adjusting to that new normal. So are there interventions or supports? Can we have, again, this was around research. So, research around outcomes. So sort of we need to do more research around how we just help survivors get back to life. And there was a number of, Sarah, step in at any point, but there was a few things that were talked about a lot. One was certainly return to work, and sort of reintegrating and adjusting with now these side effects and so on, right? These long-term effects, and how to adjust to returning to work. Another actually was, though, quite a bit with like their support system around them. So like reintegrating into like social roles again, and how those have changed now. And trying to, again, we didn't know what to call it actually. So I'm sort of speaking a bit here because we were trying to figure out, like, is it adjustment? Well, no, because actually in the in clinical psychology and so on, adjustment means something. It's not quite that, but it is sort of adjusting to a new way of life after treatment. And for some people life has changed quite a bit, and for some maybe not as much, but still that you don't go back to that normal, right? It's new, and you need to figure out how to cope and manage and adjust to that.
Yeah, no, I agree. Those are great points to make of why we kind of kept it separate. And I think, like you're saying, Robin, it was a lot of the other components and outcomes came up in that discussion of returning back to normal or new normal, but it was those phrases as well that kind of came out and just stuck out in relation to all of those things, which kind of made it an overarching separate thing on its own.
And
yeah, go ahead.
No, I was going to say we came across a concept analysis during our that was just published last year during our analysis, and this is why we sort of came to this reintegration as well. So it's sort of, I don't know much about the stroke world and so on, but that's a concept in the stroke world, for example, or in a brain injury world. This is reintegration after, and we sort of saw and so there was a concept analysis that took a lot of learnings from that sort of world and applied it to cancer survivorship. And really it was around like you have to sometimes reorganize again sort of your roles, right? And you have to adjust to these different, maybe new abilities or different abilities or changed abilities, maybe that's the right term, and so on. And that's why we stuck with that term and sort of made it its own, but it's certainly related to many of the others.
it's really fascinating and really important. I'll just mention for anyone who's interested on the call, fantastic fictional account that came, well, actually, sorry, it's not fiction, it's nonfiction because it's a biographical account. A story that came out late last year that was just read by the book club at the Canadian Cancer Society. It's called Between Two Kingdoms, and it's exactly on this point. And so it's a book by Salika Joaud. I'm happy to put it in the chat, who is a survivor of AML and AYA, and talks about how she had no idea how she would kind of have to mourn her previous life and identify almost or create a new identity for herself. So that's the exact, I think, concept that you're describing, outcome. And it was just this beautiful narrative that brings that whole concept to life.
Yeah, it is actually. You just said it very, very well around identity. Like there's a big piece around sort of this new identity. And I think for some people that might seem, again, more change than for others, but it's a new identity that people have to sort of, you know, I don't want to say, but anyway, that they have to live, like they have to learn about, right? They have to learn this new identity and how that fits in now with their life. I see a question here. Wonderful presentation, and the findings support what we hear from patients. Based on your findings, are there any existing outcome measures that you would recommend? So this is interesting. So certainly there are outcome measures for a number of the outcomes, right? So there's a number, like for fear of recurrence, for example, there are, and for a number of them. Outcome measures though, so right now, one of the things we're trying to do with this reintegration is we're doing a scoping review, and a part of that will be looking at interventions that address that sort of concept, and it's but also sort of how people are assessing them and whether there are good sort of measures to assess that idea of reintegration into life, back into sort of life after treatment. There are a number of tools that are available, and I'm sort of looking for one right now that maybe, so there's a, for example, a reintegration to normal living index, and there's a number of them out there. I'm not sure how much they're used per se in the cancer survivorship world. They may be used more like in terms of stroke and so on. So we are looking for those. But there are a number of sort of outcome measures as well around patient perception, of like coordination of care and continuity of care. I could send some of those around to the group if anyone wanted to see them. Richard, I see your hand up.
Hello, Robin.
Hey.
Resting on a bed here with a pillow behind me. So there's something that fascinates me. And Sarah, I don't believe we've ever met. And Robin would probably, if she hasn't filled you in, will give you a background. I'm a patient. I may be the only patient on this call. What's also astonishing is I'm the only male on this call. And what's also astonishing is that it was just mentioned in passing, Sarah, that all your HCPs were female, 75% of your patients were female, and it never came up. If I look at this, I'm sort of as an anthropologist from Mars, looking at your data, the first thing that stands out that's astonishing is the gender bias. And I would love to hear your thoughts. You didn't even discuss it. You didn't even mention the astonishing bias in who's listening to this talk, who were the subjects in the talk, and who's asking the questions. I want to apologize to everybody else because I'm always uncomfortable when I'm the only male in the group and I speak. I'm not trying to be dominant here. I don't have a bias towards one gender or sex, but your data are so sexually biased that it's astonishing, and I'd love to hear your thoughts on it.
Yeah, no, certainly. I mean, yeah, in terms of the majority of participants being female, and then having all of the caregivers were female as well. And yeah, I think when I think about why that may be the case, I think certainly in terms of the caregiver aspect, you know, the female role being traditionally to be a caretaker, that comes to mind. And then, I'm not so certain in terms of maybe males don't feel as comfortable reaching out or expressing their emotions or opinions on the topic.
I'm going to interrupt you because as I listen to you, these are new questions. I mean, I love that qualitative research can often lead to hypotheses and new questions. Is it worth redoing your study with men?
Yeah, it would be great. I think that's a lovely idea to look more into, maybe men who have, men survivors and men caregivers, and specifically target that group to get more and see what their input is. Yeah.
Thank you.
Absolutely, Richard, it would be. I mean, for sure. I think it was about 75%, I think, right, of the survivor caregivers who were women, and just 5% and just 25%. Am I right on that? Yeah, and just sort of 25% or just over were men. So, absolutely. Why that is? I mean, I don't know. I don't know. It was sent out, from the caregiver survivor perspective, they had to reach us, right? And I guess those were the people that reached out to us. But I think that absolutely that's a really interesting question and interesting thought to repeat this with just men. Jackie, see your hand up.
You're muted.
Yeah,
All right.
you're muted. Oh, yeah.
Hey, Robin. Hey, Sarah. Thanks for the presentation. There, I can see myself. Presentation. I wanted to comment on one thing that Richard said, and then I have a question. We find this pretty consistently across research, Richard, and I'm sure you've seen this as well. There's just overall tends to be a lower participation amongst men in health services research. I can only speak to cancer. But to give you an idea, in a comparative study that I did where I recruited people at Princess Margaret and then recruited people online, when I recruited people, this is adolescent and young adults with cancer, when I recruited people at Princess Margaret, I had a bit of a pretty much 50-50 self-identifying man versus self-identifying woman. Online, it was 80-20. So different recruitment approaches might be more amenable to recruiting men versus women, something to think about. And then one of the questions I had with regards to the presentation, I really appreciate these studies that you do, Robin, that when you look across jurisdictions. And I'm just wondering if anything came up that was different across the different, I recognize it's a qualitative study, you may not have done subgroup analysis, but just wondering if anything did come up that was different across the country.
So we didn't, I'm gonna put that over to Sarah actually, because we didn't look at it by jurisdiction in a sense. So we did do some sort of, it's qualitative, but some sort of subgroup analyses in a way to look at whether there were differences based on some factors, but we didn't by where we are in the country. So I'm just curious from Sarah's perspective, if just a recollection, she did all of the interviews, right? And I know that when I do interviews, I can sort of still hear them in my head.
Yeah, no, certainly. No, when I think about differences across the jurisdictions, nothing sort of jumps out to say this was very different. I think a lot of, I expected maybe the things to be different, if there was going to be things different, be in relation to like coordination of care or like discharge from primary care and things like that. But there didn't seem to be.
Or access to care, perhaps,
yeah,
Sarah, just because, yeah.
Yeah, or access. There didn't seem to be too many differences. Other than, I guess, some of the interviews in the Atlantic provinces, perhaps there was a little bit less mention of access issue in terms of like travel.
And I think some of that may have been because of travel from like northern BC, let's say, or northern like it's just the distances to the main centers are probably a bit longer. Yeah. And and I think the places that we do have further away in the Atlantic provinces, we probably didn't. I'm thinking Labrador. We probably didn't interview anyone from Labrador. You know, where there really is a huge access sort of issue. Yeah. Samantha.
Hi there.
Hi.
Great presentation. So thank you so much for that. I wanted to, I had a few comments. So back to that dialogue around the diversity of your population, and I think, or your sample. And, in the work that I've done doing the similar things, I've experienced the same thing in which it tends to be highly skewed towards female participants, both as it relates to patients and survivors, as well as healthcare professionals. And I think it forces us to look at how we're recruiting, because there seems to be something where we're not accessing as diverse a sample that we'd like to, despite what we've been doing so far and all of our best efforts. And another thing I would throw out there is what we're also finding is that there's very little diversity in terms of having people of color in our studies as well. And so again, I think it forces us to look at, are there different ways in which we should be doing things to ensure that the voices that are being represented are the people who will ultimately be affected by the decisions made based on these results. And so I think that's something really that we should all be thinking about. So I'm there with you. So when you have a creative idea, I'm here to share with you as well. On the topic of the outcome measures, I was wondering, had you considered the measure of illness intrusiveness? And it's a measure that was developed by Jerry Devins at Princess Margaret, and it speaks to the degree to which illness is interfering with participation in various functional realms. So say your civic duties, your religious participation, and I don't remember all the items off by heart. And one of the things I think about is that asking people, how it is, whether they're returning to normal. I think it's very heavily based on what their normal was and what their expectations are. And so, again, it's a really challenging thing to measure. I even think about, not parallel at all, but even how we've all changed how we live and work. If you were to ask us, a year from now, do we feel like we've gone back to normal? It's a very difficult question to answer. And so thinking about maybe how much does your illness interfere with this part of your functioning might be one way to look at it. Just something to think about, and eager to hear your thoughts on that.
Yeah, thank you. I will look that up. Absolutely. I mean, I think that it's around, I think you hit it's around expectation in a way, right? And it is what we expect of ourselves and what people expect of ourselves, because I do think that unless you've, you work in the field, maybe around cancer survivorship, or you've been very close with someone who's went through that, many people, probably the expectation is that, they are going to return to, where they were before their diagnosis. And I mean like socially and psychologically and even physically in some ways, right? Unless you need like a very unless, you're going in understanding that you may have a colostomy bag after, so like something just very physical that you're going to have to adjust to in terms of your life and your work. And so I do think a big part of it is expectations and knowing what you might expect, and then having the supports available, right? If depending on what happens when you do come out after treatment, but knowing what to expect and understanding and what your expectations are and what might happen, I think is incredibly important. Rather than getting out on the other side and had not had those discussions, or you didn't know what to expect, right? And then all of a sudden you're trying to figure this out. Around the recruitment part, I'm loving this discussion. I feel like this could be something that this group, that maybe there's like a working group of, this consortium that might want to think about that, right? And have some more discussion around that, because it's absolutely true. I mean, you know, and I'm really glad Richard brought it up, because I'm just thinking back to a lot of my work now. And when it's open to you know, all genders, I mean, for the most part, it's women. And even my Survivor Family Advisory Committee, I had to work really hard to have, like, there's 12 members, and I think 5 are men. But I had to work really hard to get men to recruit men for that. But I knew that that was important, and so I sought out, right, men to be involved. What was I going to say around that? Oh, and I think about, and this is a different area, but all the work that I do similarly and so on in palliative care, in the palliative care realm, or in around frailty, very similar. Almost all of the participants are female. Yeah. So I kind of think that might be something, the consortium, if there was a you know, a group of us that were interested in that and sort of understanding recruitment methods and how we could do it better, that would be fantastic.
Absolutely. You can sign me up when you start it.
Okay. All right, perfect.